Welcome, and thank you for joining us today. My name is Ellen Wilson, and I'll be the moderator for this expert briefing for the media, which is hosted by the Johns Hopkins Bloomberg School of Public Health. Today's experts will discuss the state of the U.S. pharmaceutical supply chain, proposed tariffs on imported drugs, and the implications for drug prices, availability, and domestic production. I'd like to briefly introduce our speakers. Jeremy Ballreich is an associate research professor in the Department of Health Policy and Management. His work centers on pharmaceutical economics, healthcare cost effectiveness, and access to medications. Mariana Socal is an associate professor in the Department of Health Policy and Management at the Johns Hopkins Bloomberg School of Public Health. Her research focuses on pharmaceutical policy, drug pricing, and access to prescription medications, including the global pharmaceutical supply chain. We will have time for questions following our speakers' remarks. We will take some that have been submitted in advance of the briefing and some from the Zoom chat. If you have a question, please enter it in the Zoom chat addressed to panelists and hosts. Please enter your name, media outlet, and question. We hope to cover as many as possible. Please note that participants are welcome to use images, video, or quotes directly from the briefing, and that the content is for immediate release. Participants will be muted during this briefing and it will be recorded. Let's go ahead and start. Professor Ballreich, how has the U.S. drug supply chain for branded pharmaceuticals, that is name brand prescription drugs, changed over the last 20 years?
Thank you. Great question. Branded pharmaceuticals are drugs that are protected under patents. They're protected under market exclusivities. So these are drugs that we know by name. You could think of Ozempic, Wegovy, Zepbound, Viagra, Humira, drugs that are known by name. And to kind of put in perspective, branded pharmaceuticals only account for about 15% of US prescriptions. In other words, most patients actually take generic drugs. However, even though they account for just 15% of prescriptions, they account for nearly 90% of spending. So historically, the US was a big manufacturing hub for many of these. We had significant manufacturing footprints in New Jersey, Pennsylvania, and the Carolinas doing this. However, over the past 20 years, much of the manufacturing has shifted overseas. However, it's important to note that the narrative is different than what we think about when we hear about factories shifting overseas. It is not being shifted to low and middle income countries, like when you hear about auto plants going to Mexico or China. Rather, manufacturing is being shifted to very high income countries. Currently, the three biggest countries for import of branded pharmaceuticals are Switzerland, Ireland, and Germany. These are very high income countries with high labor costs. And the reason that manufacturers have moved much of the drug manufacturing over there is because of tax policy, where companies have a very favorable tax policy. And kind of put in perspective, just in the past decade, U.S. imports of pharmaceuticals have doubled from about $100 billion to over $215 billion, most recently according to U.S. Customs data. So we are now sourcing a lot of our branded drugs from overseas, from high-income countries, because of tax policy.
Great, thank you so much, Professor Ballreich. Now a question for Professor Socal. How might tariffs impact the prices and availability of prescription drugs in the U.S.?
Thank you so much for this question, and thanks for having me. The proposal of having the proposal of having tariffs on prescription drugs are not more than having a tax on prescription drugs. And for branded products that are protected by a patent, These products, their manufacturers have the intellectual property, they have the monopoly over the production of the drug. Today, the United States pays on average 3 to 4 times higher prices than other developed countries around the world for the same branded drugs. Unfortunately, that results in year after year after year, about 1 in 4 Americans reporting not having been able to afford the drug that they needed due to cost. Patients have to skip doses, take a lower dose than prescribed, or simply not fill a prescription altogether because they could not afford it. And of course, that has significant clinical implications for the US population. And so, in the event of a tariff that has not yet been implemented for pharmaceuticals, but has been over and over proposed by the administration, if tariffs were applied to prescription drugs, one of the most immediate consequences could be price increases on prices that we are already paying way in excess of other countries. Now, parallel to branded products, we also have a separate market for generic products. And generics are typically lower cost, but they account for over 90% of prescriptions that are dispensed every day in the United States. Generics are typically used for a chronic condition or an antibiotic or a painkiller. So if anyone has needed one of these drugs, chances are you have taken a generic product. And for generic products, we do pay similar prices to the rest of the world, if not a little lower. And for these products, the biggest problem is not cost, but it's actually supply shortages. Shortages of generic products are an ongoing problem in the United States. It affects virtually all medical specialties. Hospitals every day report having trouble taking care of patients because there is a shortage of some drug that they need. And so one of the problems with having tariffs, especially on generic products, is that that may exacerbate shortages. And why is that? Well, these products are typically of lower cost, and therefore the producer has a lower profit margin on these drugs. These drugs are not patent protected, so they are typically produced in countries like India and China, where production costs are lower. And the problem, while we get lower costs for these drugs, the other side is that we also sometimes have manufacturing problems. If a company somewhere has contamination issue or the possibility of a contamination, our Food and Drug Administration wants to keep inspecting that manufacturing plant to make sure everything is okay. And in the meantime, supply can be disrupted. So one of the problems of tariffs on generic products is not necessarily high prices, which could also happen, but also manufacturing quality problems from the possibility that manufacturers may want to cut corners and send lower quality products or cheaper products even to us, and disrupting our supply.
Thank you, Professor Socal. Now we will take additional questions. And a reminder, if you have a question, please do enter it in the Zoom chat with your name, media outlet, question, and to whom you'd like to address that question. Let's start with Kylie Kosinski with NPR, WESA FM for Professor Ballreich and Professor Socal to add as well. How could tariffs impact the lower Medicare drug prices negotiated by the Biden administration?
Yeah, that's a great question. So, if President Trump ultimately pursues tariffs on countries that are a main source of branded pharmaceuticals, so if he does go through with his threats with Ireland, some of the EU countries on higher tariffs, we're talking 25, 50%, we would expect branded pharmaceutical prices to increase to reflect these additional tariffs. So if prices are higher, it would impact essentially the negotiation that would probably result in higher negotiated prices. We expect these tariffs to be passed through to the Medicare program. And ultimately, patients will either pay directly higher prices when they go to the pharmacy, or they're going to pay higher prices through their Medicare Part D premiums.
Great. Professor Socal, anything to add?
I would like to add that the Inflation Reduction Act that created the Medicare drug pricing negotiation program also created the inflation rebate penalty for drug manufacturers that do raise prices faster than inflation. That penalty also exists in other parts of our healthcare system, for example, the Medicaid program. And having penalizing manufacturers for increasing prices faster than inflation can also have an unintended consequence, because if the manufacturer cannot raise prices because the penalty might be too high, one of the possibilities is that manufacturers may want to simply discontinue a drug. We see product discontinuations happening frequently in our country, primarily for generic products because they are so low margins. And product discontinuations also contribute to having shortages. And that's one more possibility that can happen as a consequence of this potential tariffs.
Great, thank you. Here's a question from Andrew Rhodes with Helio for Professor Ballreich and Professor Socal to also add in. What drug price changes are we seeing happening now in real time? And how are they affecting healthcare providers' practices?
Yeah, so we are not actually seeing any major changes to drug prices to reflect additional tariffs. There's a standard 4 or 5% increase in list price that's been going on now for a decade, but we're not seeing any changes to prices. However, what we are seeing is a surge in imports of branded pharmaceuticals as companies are anticipating potential tariffs. So they're trying to import as much as they can before the tariffs take effect. To put that in perspective, the country of Ireland, which is our single largest source of branded pharmaceuticals imported, saw a five-fold increase in imports in the month of March year over year, as many major manufacturers such as Eli Lilly and Pfizer bring those drugs into the US before tariffs. In terms of the prescribing behavior, again, we don't really see, and we are not going to anticipate seeing much change. Prescribers are fairly insulated to some of the prices. We expect a lot of prescribers to continue to go on with what they currently prescribe.
Great. Professor Socal?
Well, I would like to add that the price to the consumer is determined very largely by their insurance design, the insurance plan and the benefit design from the insurance company. And so if a drug has a price increase, but the patient has a copay, a fixed dollar copay, let's say a $5 or a $10 copay, that patient may not feel the change in price. However, the change in price will have to be absorbed by the insurance company, and in the next year, premiums may go up. So that's one part of the story, is how important it is, the benefit design that insurance companies determine in determining how much patients pay and are exposed to higher prices. Now, on the physician side, being a physician myself, I'm well aware of physicians' good intentions in trying to help patients access the drug as much as possible. However, there is a prevailing lack of information in our country as to where our drugs come from. We just don't know. It's just an unavailable information to where each product is coming from. And often when one product is in shortage, providers also don't know which other products are available, where they're available, from which outlet, which pharmacies have inventory, and so on. So I think for healthcare providers, the challenges in prescribing are really getting access to the information. Which drugs are affected, to what extent their prices may be changing, and to what extent their inventories and their supply may be reduced, and how.
Great, thank you. Here's a question from Liz Siegert with the Association of Healthcare Journalists for Professor Ballreich and Professor Socal. Will the government take steps beyond the current drug price negotiations to help make more of these drugs affordable for seniors?
Yeah, there are currently no publicly disclosed plans. So again, the tariffs have not fully been enacted. President Trump has threatened significant tariffs on Ireland and other EU countries. They've been in limbo here on pause. And again, this is talking about branded pharmaceuticals. So the drugs that have really matter in terms of the cost and spend, but less so in terms of how many prescriptions um, are supplied. Now, I anticipate there could potentially be some help, if we do see um, prescription drugs come through at higher costs. But I don't, um, there isn't a good mechanism for the government, to provide additional help because especially in the Medicare program, we have Part D plans who actually administer the plan benefit and the cost for these prescription drugs. So, long story short, there's no definitive plans that have been publicly disclosed. And I think it's actually going to be a hard um, way to operationalize additional help for seniors.
Great. Professor Socal?
I would like to highlight that in our country, it is the drug manufacturer that sets the price for the drugs. And today, the price to the consumer, the price that our market faces for these drugs, it is frequently unrelated to the actual cost of producing the drug. Most typically, the cost of the drug represents an incentive for the drug manufacturer to continue innovating, continue pursuing new therapies. And so research has shown that the markups between the price of production, the cost of production, and the final price, there's a large markup, especially for branded, patented products. And so it will be a manufacturer's decision to what extent they will want to pass those higher prices onto the supply chain, those higher costs, incorporating them into their prices, or to what extent they will want to absorb some of that added cost from tariffs, cutting into their profit margins. But their profit margins are very, very high in the branded drug environment. And it will be a question that manufacturers will have to show how their choices will reflect in our market, how much they will want to pass on those added costs to the consumers versus how much they will want to absorb those added costs. And that can vary from the short, medium, and long term. We have seen that some branded drug manufacturers have announced plans to relocate to the United States. That is also a more long-term possibility that reflects some other decisions from branded drug manufacturers, and that should also be monitored.
Here's a related question to this conversation from Paul Hannon with the Wall Street Journal for Professor Ballreich. How long would it take to build enough capacity in the US to eliminate or significantly reduce the need to import branded drugs?
Yeah, it would take years for certain drugs. So when we talk about branded pharmaceuticals, some drugs are very simple to manufacture. They are what are called small molecules or pill, and they're typically your pills. Other drugs are much more complicated. These are drugs that are commonly referred to as biologics. So any drugs that you take via injection, and even some more complicated oral medicines, um, they require significant footprint in terms of advanced manufacturing. And, I think it would realistically take several years for a major pharma company to build a new manufacturing plant de novo. That said, there are potential some areas where there is still some manufacturing in the US that could potentially expand, add additional lines to a manufacturing. But the short answer is I don't think we're going to see a significant surge in domestic or US manufacturing of branded pharmaceuticals in the near term. That's within the next year or two.
Great, thank you so much. Here's a question from
Yeah.
Imal Akan with Epoch Times for Professor Socal. Should the United States maintain a strategic reserve for pharmaceuticals similar to the Strategic Petroleum Reserve to avoid future supply crises?
We already have stockpiling practices for some prescription drugs at the federal level, and that stockpiling is primarily focused on medical countermeasures. So drugs to treat or respond to bioterrorism and other sorts of acute emergencies. There have been proposals to incentivize hospitals, for example, to have their own stockpiles for certain drugs, especially injectable drugs that are frequently in shortage. Last year, we had the Centers for Medicare and Medicaid Services propose possibility of helping hospitals pay for such inventories. But the question is, for which drugs? We cannot have, stockpiles over stockpiles for every single drug out there. And so even a prioritization question about which drugs need to be stockpiled, that's another question. But at the end of the day, stockpiles would be necessary. The rationale for having a stockpile would be to respond to the lack of supply. And to some extent, in the long term, policies to resolve supply disruptions and shortages should be the way to go in terms of public policy and public incentives. So tracing better tracing of where our drugs come from, better information about the quality of our products. For example, helping inform today if a hospital needs to buy an injectable antibiotic, the only information they have on that antibiotic is the price. They don't know the track record of that manufacturer. They don't know the quality of that product. So having more information could help the market move towards better products. And finally, I would like to add that we do have domestic manufacturing for many drugs, but our domestic manufacturers also rely on imported inputs. For example, active pharmaceutical ingredients, key starting materials, and other things like that. And so having tariffs on pharmaceutical products coming in from abroad can actually also hurt our domestic manufacturers that currently are located in the US, because their prices may then be less competitive in the global market because now they will have higher production costs as compared to other countries.
Great, thank you. Here's a question from Richard Payarchen with Medical Economics, MJH Life Sciences, for both professors. How do you anticipate any additional drug costs or shortages due to import tariffs affecting prescription practices among primary care physicians and in ambulatory care settings? A follow-up, will they and patients need to look for alternative remedies if prescription drugs are in shortage? Go ahead, Professor Ballreich.
Yeah, so in terms of the branded drug space, and that's really most of my research focus, we could potentially see some supply chain disruption if manufacturers respond by changing manufacturing site to tariffs. Realistically, I think most major pharmaceutical companies, and this is again contingent on President Trump going through with his tariffs on key import countries such as Ireland or Switzerland or Germany. Realistically, if he does go through that, we would expect higher prices. And I don't really expect much in terms of actual supply chain disruption unless you see companies like Eli Lilly, Pfizer, Merck deciding to move their manufacturing hubs out of Ireland, Switzerland, or Germany and move them to other countries where there's a more amenable tariff policy. And anytime you change major manufacturing, given the complexity of this, there is a potential for some sort of supply chain disruption. Again, it's just a potential and no guarantee.
Professor Socal?
I would like to add that one of the problems with shortages, yes, there is the very immediate clinical problem when you as a physician, you're prescribing a drug and your patient cannot access that. which, by the way, is a problem we already have in our healthcare system even before the onset of tariffs. In 2024, we had over 300 drugs in shortage. That was a record. And it can have very significant implications in day-to-day clinical practice. But in addition to this very immediate effect of clinical disruption, for example, if you are administering a chemotherapy for an oncology patient, that may have significant consequences even for the prognosis of that case moving forward, in terms of clinical perspectives for those patients. But in addition to that very immediate clinical impact, there is also an impact on cost, because generics, they make up the majority of shortages, more than 70%. And so one of the consequences for not having availability of a certain drug is that patients then have often to turn to a branded product that is more expensive, but whose supply is actually more stable, because it is on the branded drugs' best interest to continue to supply their drugs so they can keep their market share. It's a drug that you know by name, right, as opposed to a generic. And so one of the consequences from shortages is also increasing prices, because then patients have to turn to drugs that are more expensive to start with. And those more expensive drugs are not always the best. Very frequently, and we saw this with chemotherapy shortages, with shortages of several other drug types, very frequently the available drugs are second-line drugs. And so there's many disruptions that come as consequences from a supply shortage.
Great. Here is a question from Marcia Frelich with Medscape for you, Professor Socal. You mentioned physicians need to know where the drugs are being made and get information on supply. Where should they turn for this information, and what can physicians do now to brace for this?
Excellent question. Unfortunately, the information is often unavailable. We in the United States do not have a very good publicly available system where people can find out where their drugs come from. At Johns Hopkins, we have been working hard for about a year in using publicly available information and helping make connections so that we can trace where drugs come from. And I believe it's a part of the resources that was shared in today's briefing. It has required a lot of resources, and ideally we would want to have this, as a regular publicly available tool that for example, from the Food and Drug Administration, that anybody could see the barcode of the drug that they need and they could find out where it's coming from. But unfortunately, today, even outside of a heavily resourced research environment, we just don't have that information available. I believe it would be very important to have that information.
Great, thank you. And here is a question from Jeremy Pitari with the Magnolia Tribune for Professor Ballreich. How would any of these changes affect residents in states like Mississippi?
Yeah, again, contingent on President Trump going through with the tariffs on, particularly on countries like Ireland, Switzerland, Germany, which account for major imports of branded pharmaceuticals. We would expect pharma to pass the costs on to the insurers, pass the costs, and we would expect insurers to pass the costs on to the individual patients. So if there is a 50% increase or a 50% tariff on your insulin product because it's coming from Ireland, you patients in Mississippi who, get insulin, they will either be faced with a higher cost when they go up to the pharmacy to fill their insulin, or they're going to face a higher indirect cost because the premiums of the insurance plan are going to go up. Maybe the insurance plan will absorb part of that cost or all of the cost, but will still trickle down to patients. And this is going to put additional pressure on major public insurers such as Medicaid and Medicare. This is going to put pressure on commercial and employer insurers. So, there is a significant potential for some financial hardship on patients in Mississippi if we go through with some of the tariffs that have been discussed.
Great. Just as the last question for both of you, if you could comment, and let's start with Professor Socal. One motivation of the U.S. administration is to increase U.S. manufacturing. How likely is that to happen for generic or branded drugs?
There is an ongoing concern beyond shortages and the clinical application of drugs. There is an ongoing concern about national security, having access to prescription drugs as a national security matter. I mean, we have military deployed everywhere in the world, we have military operations, and we also have the very real public health of America to take care of and make sure it's sustainable. So having a sustainable supply of prescription drugs has this national security element. And that's part of why the current federal administration has also opened an investigation on the possible impacts of tariffs that is still ongoing. And I think that's part of the rationale for bringing in manufacturing back to the US soil. Now, it's not a guarantee against shortages because we know there are natural disasters that can happen even in US soil. We've seen it with unfortunately floods and hurricanes affecting manufacturing plants for pharmaceuticals. And then the question is, should we produce every single drug that we need? Which types of drugs should we continue to rely on the global market, and which types of drugs are more strategic for us to produce domestically? And I think that's where we also need more information to help incentives be targeted to the drugs that we need the most.
And
Professor Ballreich, yes, go ahead.
thank you. Tariffs are a very blunt instrument to incentivize domestic U.S. manufacturing of the branded drugs that we use. If we really want to think about how to onshore or bring domestic manufacturing back, we have to first acknowledge the manufacturing of many branded drugs are highly complex. They're considered advanced manufacturing. It's not just a very simple chemical plant, but these tend to be very complex. And we have to think about tax policy, because that's why many of the manufacturers have located outside of the US, particularly to other high income countries. And we also have to think about other subsidies and making sure we have a very well developed, well trained workforce. So, really thinking more along the lines of more nuanced policy, maybe look at something like the CHIPS Act in terms of how to incentivize US production of these very advanced, very complex branded drugs.
Great. Thank you to Professors Ballreich and Socal for your insightful answers. We will email the links to the resources mentioned today and shared in the chat. And with that, I'd like to say thank you again to everyone for joining us today.
Thank you.
Thank you.